in, please share your title or affiliation in the chat so we can kind of get an idea of who's with us today. I think we'll begin the recording. I know it's like a notification. I never know which platform.
We are recording.
Perfect. That's what I need. Great. All right. Well, you're all having to listen to me, and I'm sorry for that, but I am Elizabeth Cope. I am the Chief Programs and Science Officer at Academy Health. I oversee all of our scientific programming and our externally funded work that we do. And we are the professional organization for health services research. And I work together with Lucy and others to help support this component of the Scientific Resource Center. And so leading this conversation with me today is Dr. Lucy Savitz, Senior Innovation Advisor at UPMC Health Plan Center for High Value Healthcare, and also professor at the University of Pittsburgh's Department of Health Policy and Management in the Graduate School of Public Health. And fun fact, at least personally for me, immediate past chair of Academy Health Board of Directors. So if you are concerned about me, you can email Lucy and she will deal with complaints. All right. And so today, I guess, yes, with the agenda. So today, what we're focusing on are the reports that you see noted here. So we are going to start by hearing a few words from our colleagues at AHRQ, and then we'll dive in. We're going to hear from two different report authors talking about their reports, and then we have invited an esteemed group of colleagues to join us as discussants and help us kind of think through some of the policy, health systems, and evidence issues that we are seeing in these reports. Let's go to the next slide. Yes, so at the conclusion of this webinar, we do hope that those in attendance will have gained insight into the learning objectives that we have. And at the end of the meeting, we will share a link in the chat to an evaluation survey that is required for those interested in earning continuing medical education credits. So, and you've got the learning objectives here identified on this slide. And so I think what I'm going to do now is turn it over. So I am pleased to welcome Dr. Sushi. You're the Acting Director of the Evidence-Based Practice Center Division at AHRQ. She supports the conduct of systematic reviews of clinical and other healthcare-related interventions, collaborating with the CDC, CMS, and NIH, and other non-federal partners to foster evidence-based decision-making for clinical practice guidelines, research agendas, and coverage decisions. For the reports being highlighted today, she served as the AHRQ liaison between the Center for Medicare's Hospital and Ambulatory Policy Group and the Evidence Review Team, where she oversaw the development of the evidence reviews according to established methods standards. She is going to kick us off with a brief overview of that process, and then she will be introducing today's authors and discussants. So without further ado, please welcome Dr. Sushi.
Thanks, Elizabeth. Hello, everyone. Can you hear me?
Yep, we can hear you.
Great. So AHRQ, through its Evidence-Based Practice Center program, has been a trusted source in providing the scientific foundation for healthcare decisions based on comprehensive, unbiased, standards-based, systematic reviews of the scientific literature. Today, we will highlight a recent success story of our collaboration with our sister agency within the HHS family, the Centers for Medicare and Medicaid Services, CMS. Now, CMS sets the Medicare physician fee schedule to reimburse the professional services of physicians and other healthcare providers. Traditional Medicare doesn't generally cover routine preventive dental care, such as exams and x-rays, or more extensive services like root canals and dentures, which we collectively refer to as dental services. In recent years, however, the physician fee schedule final rules have identified specific clinical scenarios where payments could be permitted for certain dental services when they are integral or inextricably linked to other covered medical services. That is, when a patient's health outcomes as a result of a covered medical services is improved by the provision of the dental service. So we are excited to be sharing the findings from the AHRQ evidence reviews that informed the payment policy for two of those clinical scenarios. One, for reducing adverse events in those receiving chemotherapy for cancer, and second, for those with end-stage chronic kidney disease requiring dialysis. So the development of the annual physician's fee schedule by CMS follows a very specific timeline, giving our evidence review teams a narrow window of a few months to conduct the evidence review. We had to adapt our usual rigorous methods, work iteratively with the team at the hospital and ambulatory policy group at CMS to identify acceptable ways to streamline and accelerate the traditional systematic review process in order to create a rapid evidence product that would meet their needs and timelines. I'd now like to introduce you to the authors of the evidence reviews. Dr. David Hickam is an investigator with the Scientific Resource Center for the AHRQ EPC Program. He has more than 30 years of experience as a health services researcher. In his current role, he provides support for topic development activities and the internal review of evidence reports. Previously, he had served as the scientific program director at PCORI and as co-director of the Health Services Research and Development Program at the VA Medical Center in Portland, Oregon. Dr. Nanguneri Nirmala is the co-founder and CEO of Vindhya Data Science, a women's-owned small business which provides services of bioinformatics, data science, and evidence synthesis. Nirmala has had a career in the pharma industry for a span of over 20 years. Until 2015, she was at the Novartis Institutes for Biomedical Research, where she held leadership roles in structural biology and in bioinformatics for preclinical research and also translational medicine. Subsequently, she held a faculty position at the Institute for Clinical Research and Health Policy Studies at the Tufts University School of Medicine. Welcome, David and Nirmala. A special welcome to our panel of discussants. We have with us today Dr. Natalia Chalmers, who is a diplomat of the American Board of Pediatric Dentistry, as well as the Chief Dental Officer and Head of Clinical Innovation at Overjet. She is board certified pediatric dentist and a 2025 American Academy of Pediatric Dentistry oral health policy expert. With more than 20 years of experience spanning clinical practice, research, industry, and regulation, she has devoted her career to transforming data and science into actionable insights that improve patient care in oral health. Joining her is Dr. Michael Glick, Executive Director of the Center for Integrative Global Oral Health and a Fields Rayant Endowed Professor of Integrative Global Oral Health and Professor of Clinical, Preventive, and Restorative Sciences at Penn Dental. Dr. Glick has been active with the International Dental Federation since 2007, serving on multiple committees, including co-chairing the Task Team Vision 2030. He has also led establishment of the FDI's Vision for 2020 and was most recently the primary author of its Vision 2030, giving guidance for a global interdisciplinary and integrative role for oral health. We also have with us Dr. Dan Pihlstrom joining us, who is a dentist with over 20 years of experience. His clinical practice is focused on general dentistry with an emphasis on care of medically complex patients, including those undergoing head and neck radiation, chemotherapy, and organ transplant. He serves as Chief Dental Officer of Permanente Dental Group and as a Senior Affiliate Investigator at the Center for Health Research in Portland, Oregon. His research interests focus on medical dental integration, population health, and clinical dentistry. We look forward to an exciting program for the next couple of hours. Thank you.
All right, I think we are now passing the baton to Dave.
Thank you, and thanks to everyone who has joined the webinar today. We look forward to having these discussions. So we can go to the next slide, please. Just like to thank the individuals who collaborated with me on this project. These are all people who Scientific Resource Center, and we're based at the VA Medical Center in Portland, Oregon. Next slide. So in my brief presentation today, I'd like to briefly review the original topic nomination and the timeline for the report that we developed, how we scoped the project, particularly the breadth of the topic, and the strategy for determining relevance of individual studies. I'll briefly talk about our interactions with the nominator, our overall findings, and hopefully give you some insight into some of the lessons learned in this activity. Next slide, please. So as Dr. Iyer had already mentioned, this was a topic that was brought to the EPC program by the Center for Medicare and Medicaid Services. They had previously approved limited dental services in some specific clinical circumstances, including when the services are an integral part of specific treatment for a primary condition, such as fractures of the jaw, prior to or during treatment with organ transplants, surgical cardiac valve replacements, or valvuloplasty procedures, and also prior to treatment for head and neck cancers. I do want to draw attention to the coverage that had been established for organ transplants and cardiac valve replacements that were largely revolved around the concern about infectious complications of these two types. As was mentioned, CMS was interested in possibly expanding coverage to other clinical conditions, and noted that patients receiving immunosuppressive cancer chemotherapy often are referred for dental evaluations and dental treatments. This was something that had become relatively widespread in the medical community, and those dental services had not been covered by Medicare. And this project was brought to us in the latter part of 2022. We conducted the study beginning with the scoping of the topic and our initial literature searches in December of 2022, and we completed the project in February of 2023. So that spanned a period of about 11 weeks. So this really was a rapid review. Slide, please. So in sort of defining the PICOTs of this project, we considered initially the types of cancer that would be treated with multi-agent broad-spectrum chemotherapy, the stage of the patients with cancer, the range of types of cancer treatments, including additional treatments beyond chemotherapeutic agents, and the documentation of the presence of pre-existing dental disease, and the types of dental treatments that were recommended to occur prior to initiating the cancer treatment. Next slide, please. So we used a causal model to guide the review of this topic. As you can see, this has elements of both an analytic framework for looking at the evidence, as well as a biological model based upon infection. So if you start on the left side, focus of this project was dental care as sort of a single episode that occurred prior to initiating cancer chemotherapy. And then followed shortly thereafter by initiation of the treatment. And this then led to certain considerations. A couple of important outcomes that are there, the ovals on the lower part of the slide. The effect of the therapy on mucositis, and the development of osteonecrosis as a specific bony complication in patients receiving some types of chemotherapy agents. The chemotherapy itself does influence the immunology and the resistance to infection, which is manifested as sort of the bacterial load in the teeth and mouth. And then that sometimes, because of the immunologic compromise, can lead to serious infections. So serious infection rate was another outcome that we included in our scoping of this project. Also, I just mentioned that besides treatment that is administered by dentists and dental hygienists prior to the initiation of chemotherapy, patients themselves also perform routine daily dental hygiene, which could also be a possible influence upon the rates of these outcomes. So the three most important outcomes that were looked at in this project were infections, the incidence and severity of mucositis, and the incidence of osteonecrosis. We also did look at some other cancer-related outcomes, such as adherence to treatment and overall sort of general measures of quality of life. And we can go to the next slide. So we did a fairly broad Medline search covering the period from the inception of Medline until the end of December 2022. We did sort of sequential dual review of the titles and abstracts by 2 reviewers. We adjudicated disagreements between reviewers through sort of discussion and consensus. We did full text review of included studies by only 1 reviewer. We flagged systematic reviews that we identified in the Medline search. We also did a separate search, which you would characterize as sort of a gray literature search, looking for professional association guidelines. And we followed up by looking at websites and making phone calls to try to make sure we captured the existing guidelines. In the report, we performed narrative synthesis. We had no plans to conduct meta-analyses based upon really our expectation of what we were going to find in this rapid review. We included in the report rather complete tables that provided information about all of the identified relevant studies. We did not use formal strength of evidence ratings. Our goal in this activity was to try to provide the nominators with complete information about the range of studies that could influence or be considered part of an evidence base. We did not, our agenda was not to provide detailed recommendations to the nominator. Next slide, please. We, as I already said, we're really pretty all-inclusive. We had minimal exclusions of individual studies based upon their study design. So we included cohort studies, randomized trials, and even case series that could provide information about rates of outcomes, but really didn't provide information about efficacy of the interventions. As I had mentioned before, CMS had previously approved coverage for patients with head and neck cancer. We did not exclude head and neck cancer from our search, feeling that this did fall within the scope of the types of treatment we were looking at, and also could be useful to the nominator. So we wanted to provide that information if they wanted to use it. Next slide, please. So this was the results of our searches. We had a total of 2,765 citations. We identified 215 for full text review. And after the full text review, we identified 26 relevant primary studies included in the report. And we did exclude really small case series, so we had that exclusion. We also found 7 previously published relevant systematic reviews and 5 clinical practice guidelines that made recommendations regarding dental care in cancer patients. And I don't know, this is, I'm not going to sort of go into this. Originally, we were intending to focus only on infectious complications, but we did find that the scope of the treatments and outcomes that we were looking at led us to include osteonecrosis, which technically speaking is not an infectious complication. So just to sort of say, we're talking about things that sort of plausibly are related to infections as well as osteonecrosis outcomes. Next slide, please. So the 26 included studies sort of fell into these categories of outcomes. There were 2 comparative cohort studies and 3 case series looking at infectious rates, 3 randomized controlled trials, 1 comparative cohort study, and 5 case series examining mucositis, 9 comparative cohort studies, 2 case series, and 1 case control studies looking at osteonecrosis, and then 1 comparative cohort study that had quality of life as an outcome. We did not find acceptable studies that looked at cancer control outcomes. So that really was beyond the scope of this review. Next slide. The studies did have a lot of methodological limitations. The comparative cohort studies generally did not use statistical methods to adjust for confounding, although In a few cases, they did use statistical techniques. One of the randomized controlled trials only reported mean values of the outcomes, did not perform statistical analyses. This are it's a relatively poor quality randomized controlled trial. And as I said before, the case series, we really only reported those for estimating the rates of the primary outcomes to see if we could make any generalizations about the outcome rates. Next slide, please. There were 7 systematic reviews, but we excluded 2 of them because they were more than 10 years old. But basically, these systematic reviews consistently cited a shortage of high-quality evidence. We looked at the studies that they did identify in those reviews, and we only identified 1 study that we had not identified in our Medline search. We did look at that study and incorporated it into the tables that were in our analysis. The clinical practice guidelines were from professional organizations, and they all recommend dental evaluation prior to intensive cancer treatment. They all were based their recommendations on some component of expert judgment. And the strongest claims for evidence-based recommendations in these guidelines was the category of preventing osteonecrosis. Next slide, please. So our conclusions were this, and again, it's a brief presentation here. I did not go into all the details about the studies that we found, but we found that although it was generally limited and of low quality, the available evidence was supportive of the concepts that pretreatment dental care may reduce the incidence of oral infections during chemotherapy. This is basically based on a small number of comparative cohort studies. Secondly, to reduce the severity of oral mucositis during chemotherapy. This is primarily based upon a couple of randomized controlled trials that found that the incidence of mucositis, the actual rates of mucositis, didn't change, indicating that mucositis is really caused by chemotherapy. It's not really influenced by dental care. But the patients who had received pretreatment dental care prior to chemotherapy in the trials had shorter duration and less severity of the mucositis when it occurred. And finally, there is evidence from large-scale and fairly well-conducted cohort studies that pretreatment dental care can reduce the incidence of osteonecrosis of the jaw during and after treatment with bisphosphonates or other types of chemotherapy agents that target malignant bony lesions. And this really has to do with the fact that osteonecrosis in this patient population is more likely to occur in areas of decayed teeth. And the concept here is that you can prevent the need for pulling teeth and things like that after undergoing the treatment if you identify and manage those problematic areas prior to initiating the treatment. And my apology to all the dentists who are here about my rather imprecise description of dental care. So anyway, thank you. And I hope this was helpful.
Thank you very much, David. And what we're going to do now is turn to our discussants for their initial reactions. We have about 10 minutes, and we'll hear from the second report, repeat that, and then open to a more moderated discussion. So Natalia, would you like to go first?
Thank you. It's such a pleasure to join this group and had the privilege of working with you all when I was at CMS, CMS as the Chief Dental Officer, when these reports were being developed. And my remarks will center around what matters most, and that is the patient, because we all know someone who's been diagnosed with cancer. Imagine someone, acute leukemia, and their world has just narrowed to a single question, right? Will the treatment work? And the last thing that may be on their mind, and maybe even on their care team, is what about their oral health? But we know, and I just wanted to share this, that and what this review confirmed is that for a very meaningful subset of patients, the mouth is just not a side issue. We learned that the bacteria travels into the bloodstream during neutropenia, which is part of their treatment. And that mucosal breakdown really makes eating and swallowing very difficult. Just for context, when I was at NIH, we treated a lot of patients and got to see pretty severe cases of graft versus host disease. But for some patients, the chemotherapy, the mucositis was so bad, they actually had to go off treatment. So imagine now these, oral complications were basically, put side to side with continuing the treatment or not. And as David shared, the evidence is not uniform. We have to be honest about it. It was very disappointing not to find, hundreds of studies that were well designed and supported. But for the payment policy change, these studies were sufficient. And I just wanted to highlight that, this was in a string of a lot of work done internally by the CMS team, supported by external stakeholders who provided their perspectives. And, really the AHRQ synthesis of evidence was the chair on the top that was able to help us provide these meaningful changes in the law to allow for these payment changes to occur. And so, one thing you didn't hear mentioned at all in this review is the cost and the cost effectiveness of care. And that was not, that was by design because we knew that the strongest connection to changing the policy was actually clinical, right? The same way David talked about, this is a clinical problem. This is really no longer about the teeth. It's about the underlying condition. And it was absolutely essential to change these payment policies. So I think this is a great example where, identifying a high need cohort of patients who don't have access to dental services, looking at the science, synthesizing that with this amazing team, resulted in a meaningful change in payment. And so today, if you have any of these conditions, you find a dental provider who's enrolled in Medicare, you will be able to receive these services. They will be paid for by Medicare. Very meaningful impact.
Great, thank you for those comments. I'm going to turn to Dan next and then Michael. Dan?
Yes, thank you. David, I think you did a pretty good job actually of sort of talking about the dental issues specifically. I think it's really fantastic to have evidence reviews like this because just, for example, the finding that mucositis does not seem to have a strong impact, or the reduction of mucositis is not as pronounced as, for example, prevention of osteonecrosis. It's really helpful to have that because so much of the emphasis on the dental examination prior to chemotherapy is on, educating the patient on what they can expect, how to keep themselves healthy. And then, I think the strongest evidence is around prevention of osteonecrosis from these resorptive medications that so many of these patients are put on. And you're right. I mean, typically after the dental exam is performed, if a patient needs a tooth taken out, that's like the time to do it, is before they get put on those medications, if it can be done safely, because a lot of times these patients are also very sick and on other medications. So just having the coverage, having having physicians aware of it, I think just creates so much better outcomes for the patients, even if they are somewhat subtle outcomes in some cases. Having the patient come in, see the dentist, discuss the oral care prior to chemotherapy is just really important for the patient as well as the healthcare team in general. In terms of connecting with them if there are issues, there are lots of sort of other benefits of having this type of communication between the medical providers and dental providers. So I think it's great to have the evidence to support what we're doing.
Great, thank you, Dan. Michael. Michael Glick, you there? Taylor, does it look like we lost Michael?
I know he's
There you are. Michael, are you still?
How about this? Am I back?
There you are. There you are.
Thank you. So again, thank you for the invitation, and thank you for Natalie and Daniel, as well obviously Dr. Hickman for these presentations here. The report tackles a problem that's been neglected for a very long time, and that's why I appreciate that it's been done. My background is treatment of medically complex patients. That's what I did in my clinical care for many, many decades. And thank you also for not mentioning how long I've been doing this. Everyone else at 20. So I appreciate that as well. Thank you very much. So the strength, osteoid necrosis prevention, no question about it. Large cohort studies, 12,000 patients and so on and so forth. I think the big one here is that the level of directional consistency across settings, investigated time periods is very meaningful. And it doesn't require randomized controlled trials. So that to me was very encouraging. It sort of helps us moving forward. The serious infection prevention also, a biological case is very, very compelling. And there again, large studies that show that we can prevent these serious infections, which is very, very important. And lastly, what I also appreciated was the consensus among these 5 professional societies. That type of consensus, I think, is very important for CMS to find that type of consensus behind. So that one was cool. So the directional signals are there. It will be very hard to clarify before I turn into something a little bit different. So a couple of small things. Although Natalia talked about the monies and the cost may not be that important, but I do believe that doing some kind of cost offset estimate or cost effectiveness analysis might have been very helpful, specifically for payers, obviously. So I understand why it wasn't done, but moving forward, it would be very helpful, I think, if we had something like that. Osteonecrosis, because we dealt with cancer patients, my assumption is that we only looked at intravenous type of bisphosphonate therapy and not oral. Small little mentioning that oral may not have been included could have been very helpful because the difference of getting osteonecrosis from oral is significantly lower than doing it from an IV infection. From a methodological standpoint, almost everything comes from observational trials, that's what's available, so that's cool. It doesn't change the directional conclusion, but it limits how strong these conclusions can be stated, obviously. But I think the authors did a very, very good job when it came to that. And secondly, obviously, the oral versus intravenous type of bisphosphonate, and mentioning that would have been very helpful. Most of us who deal with these type of patients, we know there's a difference there, but maybe some who are not that informed, that might have been helpful. And then there's some confounding in these studies, obviously, because they're certainly run in one direction, but patients who receive pre-treatment dental care were probably more likely healthier than those other and more health engaged than others. And that's a type of collider bias that we see in a lot of these epidemiological studies that would be good if it could be addressed. I don't know if we can fix it, but address it would be very helpful. So none of these concerns overturn the findings, but the constraints the precision of the claims we can make from them. So again, bottom line, clearly support risk stratification coverage recommendation, but it's not a blanket one. So that could have been more specific. I think we have to be a little bit more cautious when we frame, depending on the target agents, CAR T cell therapy. Population is largely absent from this evidence base, but again, it was probably based on what was found, obviously. And then obviously the report does not yet make the complete argument that CMS and health plan medical directors will need. Again, going back to the efficiency piece, which is missing. There's more the effectiveness piece rather than efficiency piece. So that type of risk stratification is probably underdeveloped, and hopefully that can be done in next turnaround. Bottom line, authors done a hard work establishing what the evidence show. The next stop is making the case for who should be covered and what cost. And that's the argument that would probably move policy forward.
Well, thank you for these initial reactions, discussants. We're going to hold off until the moderated discussion to dive a little bit deeper into these topics. Taylor, why don't we advance to the next slide and invite our next author to present.
Okay, thank you everyone. Good afternoon. My name is Nirmala and I'm from Vindhya Data Science. Thank you for the opportunity to talk today on linking dental services to treatment outcomes for chronic kidney disease. In the next slide, we show the names of all the people in the team who participated. I specifically would like to acknowledge our AHRQ partners, Suchitra Iyer and Christine Chang, as well as our CMS partner, Natalia Chalmers, and from whom we learned a lot about this topic. I have to say that at a personal level, once I was looking into the evidence that we collected as part of this rapid review, I just got much more disciplined about my flossing every night, because the connection with the oral health started to strike home. You know, this is something we all kind of ignore until right before the week of a cleaning that we have to go to the dentist. But reading this study really gave me this opportunity to be sensitive to that. So let's go to the next slide, and where we're showing a schematic representation of a causal model depicting the relationship between CKD and oral disease. So some numbers here. CKD impacts about 35 million people in the US, and globally it's about 850 million people. It's a multifactorial disease, and in fact, the risk factors are shared between periodontal disease and chronic kidney disease, meaning diabetes, obesity, smoking, and poor nutrition affect both these diseases in a similar way. And you can see in this causal model that systemic inflammation, which is a result of impaired immune function, plays a role in periodontal disease as well as in chronic kidney disease. And without going into too much detail, all I have to say is, in fact, almost 100% of patients with CKD on dialysis have periodontitis. You know, so this is what has been reported. And so a change in the oral microbiota could actually change your inflammation profile. So there are many interconnecting factors between the two diseases. And there is a hypothesis that actually there's a bidirectional relationship between periodontal disease and chronic kidney disease. So this is a very, for us, it was a very interesting topic where we had the opportunity to learn both about CKD as well as about periodontal disease. And in the next slide, we show the 5 key questions that were part of this study. And they are the effectiveness of dental services in improving health outcomes for patients with CKD at stage 4. That is key question 1. Key question 2 is in people who, when provided prior to the placement of the hemodialysis access. And key question 3 were patients who were on hemodialysis. Key question 4 was the effectiveness of dental services for patients with CKD on peritoneal dialysis. And key question 5 is, what are the dental services and guidelines for people with CKD? And in terms of our PICOTS criteria, we used obviously a population of adults with CKD stage 4 or 5. It has to be mentioned that we collapsed key question 1 and key question 2 because we didn't really find any studies that specifically singled out patients prior to the placement of hemodialysis access. For dental conditions, we included everything, namely periodontitis, gingivitis, endodontic abscess, caries, etc. Home oral hygiene was excluded as agreed upon with our AHRQ collaboration. And for primary outcomes, we note kidney function, which would be a normal outcome. Inflammatory outcomes based on the causal model that we kind of looked at the schematic, and nutritional markers, which is a key component of chronic kidney disease. Secondary outcomes were either infectious disease or mortality related outcomes. We included the time period of the 10 years preceding the date when we started the study, so 2014 to 2024. And then the systematic reviews we included were from 2019 to 2024. We required a minimum follow-up of 3 months or longer. And as you'll see, most of the follow-ups are really 3 to 6 months. There was even one study where the follow-up was only 6 weeks. And we wish that some of these studies were followed up for longer. And we did not limit any countries. The setting was all countries were included in this PICOTS criteria. So going to the next slide, we're just going to summarize the literature search and the screening of articles that were included in the rapid review. So from 515 articles that were screened at the abstract level, after looking up these articles and the abstracts as well as the full text, we excluded about 39 articles, and then 23 articles were included in the rapid review, of which 7 were systematic reviews, 15 were primary studies, and we obtained 1 guideline as a result of this search. We later on did additional hand searches and we were able to recover 2 other guidelines. And this table actually gives us a high-level view of the number of studies for each key question. As mentioned before, key questions 1 and 2 were collapsed into one. And then we have key questions 3 and 4, hemodialysis and peritoneal dialysis respectively. And key question 5 is a question about guidelines. And as you can see, it's really not, a well-populated table. There are only a few studies, just like we saw in the previous presentation. However, a lot of different lab markers were used to study this, and this is what we'll look in the next few slides, giving a very high-level overview of the results that were reported. In the next slide, we'll see the summarization of the evidence for key questions 1 and 2. And here we see mainly 2 categories of outcomes. One is kidney function outcomes, and the other is inflammatory outcomes. For kidney function, we see that the glomerular filtration rate, the estimated GFR, was increased. So these cream color columns represent systematic reviews, and the green columns represent primary studies. And we have here a notation of whether the studies were high or low based on the criteria that we used to assess these studies. And you can see that the eGFR is of the 3 systematic reviews, 2 of them showed an increase. And then of the 2 studies, only 1 measured it, primary study, and there it showed an increase. So we would consider this evidence weak. And for CRP, we consider it a moderate evidence because in all the 5 studies where CRP was measured, there was a decrease in CRP after the periodontal treatment. I must say that for all of these studies, except in 1 case, which was a root canal therapy, everything else, the dental treatment intervention was non-surgical periodontal treatment. So you can see a consistent reduction of CRP, but similarly, concomitantly, you can see the inflammatory markers like interleukin-6, interleukin-1 beta, and TNF, tumor necrosis factor alpha, all show a reduction. Okay, they're not measured in many studies, but where they were measured, they show a reduction. Still, we would call the inflammatory markers other than CRP as weak evidence, and the CRP should to be of moderate evidence. Moving on to key question 3, which is shown in the next slide. I'm just showing you a high-level overview again of the inflammatory outcomes, kidney function outcomes, and in this case, we have some cohort studies where they reported on mortality and related outcomes. Again, moderate evidence for a reduction of CRP across the included systematic reviews and in 2 out of the 5 primary studies. Weak evidence that IL-6 levels are reduced. And for kidney function, there was really insufficient evidence, not enough studies reported on kidney function. For mortality and related outcomes, there was weak evidence that there's a favorable outcome for all-cause mortality after the treatment, but insufficient evidence for all the other outcomes. So we'll go into slightly more detail in the next 2 slides. So in the next slide, we have the kidney function, metabolic, and inflammatory outcomes. And you can see here that, again, let me draw your eyes to CRP. So in all of the systematic reviews, you could see a reduction. And in 2 of the 5 primary studies that we were including in this review, we could see a reduction of CRP. Similarly, IL-6, 3 out of 4 systematic reviews showed a reduction, and 1 out of the 2 studies showed a reduction in IL-6. And TNF-alpha were measured in reported in 1 systematic review, measured in a primary study. Again, we would call this a weak evidence for IL-6 and TNF-alpha, but the CRP, as again you can see, is consistent, and we could called it as moderate evidence for this. So going to the next slide, which shows the result of mortality and related outcomes. Again, we're talking about key question 3, that is hemodialysis, patients on hemodialysis. You can see the unfortunate, if you want to call it that thing, is that there's not a consistent measurement of similar outcomes across the included studies. Whereas for all-cause mortality, we have 3 studies that actually measured these outcomes, and it showed a reduction in all-cause mortality that was statistically significant. For all the other outcomes, the outcomes are in the right direction, if you can call it that, for the most part, except these 2 that were not significant. However, the evidence is insufficient because they were in 1 study or at the most 2 studies. This was the overall summary for key question 3. Moving on to key question 4, which is in the next slide. Again, we see a summary of inflammatory, kidney function, and mortality-related markers. Once again, I'll take you to our favorite inflammatory outcomes. Again, you see a consistent reduction of CRP across the systematic review shown in cream, or the primary studies shown in green. IL-6 in this case, again, measured in fewer studies, still shows, a significant reduction in a couple of reviews and a primary study. And for all-cause mortality and infectious disease, we see a reduction, but again, measured in only 1 study. We would therefore call it insufficient or even no real evidence. So these are the high level outcomes summary for the key question 4, which is patients on peritoneal dialysis. There is some conflicting evidence for eGFR. Again, it's in 1 systematic review. We call that insufficient evidence. So now, if you let's go to the next slide, and you can see the results we got for key question 5. So we had guidelines summarized from KDIGO, NICE, and the European Renal Best Practice Group, and they were all consistent. There were no recommendations for dental care. So, which was an interesting finding compared to what we heard for the previous presentation. But in addition, we also extracted some interesting surveys that were done in undergraduate dental programs, nephrology fellowships, GPRA, GD programs, etc. And overall, what we heard in the survey results was that there was a lack of a consistent protocol or evidence-based guidelines for dental treatment of patients with CKD. In fact, in some cases, the protocol used an antibiotic prophylaxis taken from the AHA protocol, dated as far back as 2008. And majority of the protocols are based on a medical consult or literature review or from up to date. And one thing noted in the surveys is that there was a lack of collaboration between nephrologists and oral health professionals. And in fact, the survey authors recommend that evidence-based guidelines needed to be developed for safe dental treatment of patients with CKD. So let's go to the next slide and talk a little bit about the limitations in the evidence base. As we've already mentioned, the population was heterogeneous. We could not really segregate by obesity level or smoking status, etc. Underlying comorbidities were just not reported, so we could say that the findings could be impacted in terms of generalizability. In the terms of the interventions itself, there were different definitions of periodontitis severity from study to study, or different standards of dental treatment for periodontitis. And as you can see from what we reported in the outcomes, there were inconsistencies in the type of outcomes measured. Follow-up periods were short, but most importantly, what we saw, what we feel, and we would say is a limitation, is there should be an integration of dental with medical health records. that could shed additional light on the evidence, not only for CKD, but many other indications as well, just based on the comorbidities, etc. So if we go to the next slide, I just would like to summarize overall for all the key questions. And without reading too much of all this text, what we can say is for inflammation, we saw moderate evidence all over the place for CRP, weak evidence, again, reductions in inflammatory markers, weak evidence for interleukins and TNFs and so on. For kidney function, we saw weak or actually insufficient evidence. And for mortality-related outcomes as well, we saw weak or insufficient evidence. And again, for the guidelines, really no recommendations for dental care as of the time of when this report was written. So let's move on and finally just talk a little bit about the impact of this review. And this rapid review contributed to the 2025 Medicare Physician Fee Schedule Final Rule, where fee-for-service Medicare payment may be made for some dental services for patients on dialysis, namely, end-stage renal disease in CKD. And so this is a good outcome for the patients who are undergoing this disease. So I would again like to thank all my collaborators, thank the team that helped us do this rapid review really rapidly. And I would like to stop here and listen to any feedback.
Thank you. Excellent, excellent overview of the report. Let's turn back to our discussions for their initial reactions, and then we'll have time for a more detailed moderated discussion. Michael, let's start with you. Your thoughts. You're on mute, Michael.
How about that? Is that better?
Yes.
Are you sure you want to hear me? Okay. First of all, congratulations. This was an absolute outstanding rapid review. The PCOT framework is explicit, risk of bias tools were applied across all the studies, full text screening was done in duplicate, excluded studies are documented, and for a rapid review, this is above the norm, so congratulations. For those of you who don't know, when you talk about rapid review, a systematic review should take around 1,000 hours. So doing this in 2-3 months is astounding. So headline first, C-reactive protein, no question about it, is again directional. Everyone showed the same thing. It's an inflammatory marker, and it's consistent across all the dialysis strata. But there's just one thing we need to remember though, and that is that it's a credible biological mechanism when we talk about C-reactive protein reduction, but it's not the clinical endpoint. So if you can reduce it, doesn't mean exactly that we have reduced any inflammatory impact that might be associated with it. But the bridge exists in this evidence base, but it's built from observational cohorts and data, and the changes, the weight that carries needs to obviously be taken into consideration, no question about it. Another thing that I think was unfortunately not talked about enough, which I think was fantastic, was the endocarditis thing. I mean, that the hazard ratio as 1.04, that means it's non-existent, essentially non-existent. And this is one place in dentistry, for instance, where we pay a lot of note to should, for instance, patients on hemodialysis have antibiotic prophylaxis, yes or no, and so on and so forth. So this finding that it was not associated with endocarditis to me was cool. I mean, I've never seen anything like that before. The big problem I have here are two. One is stage 4 kidney disease is really the stage before you go on hemodialysis. And if you want to talk about prevention, unfortunately, there was not enough evidence to talk about stage 4 by itself. So I think this could be hopefully NIDCR or someone is listening right now to fund the studies specifically included stage 4, which would be very, very helpful. And another thing is based on that as well, going back, yes, you combined key question 1 and 2, but because what we found here with nothing about stage 4, the key question 1, unfortunately, could not be answered, obviously. So bottom line, great study. One more thing missing. Not your fault again, but it doesn't seem to have any guideline support. If you look at all the big ones, the kidney disease improving global outcomes, NICE, ADA, the European Renal Best Practice Groups, etc., they don't have dental care in it anywhere. So hopefully, if we can get them to start to pay more attention to this and using this review as an example, that would be a great outcome, obviously. So that's my quick review.
Great. We appreciate that, Michael. Thank you very
Great
much.
findings and very, very helpful.
Thank you, Natalia.
Yeah, and I just want to echo that this was an exceptionally great collaboration with the team at AHRQ at CMS, and we couldn't have been happier to work together. The monthly updates, it was, an exceptional team, and the output speaks, I think, for that. But let me start where all of this work really started, and that is, again, to think about the patients. As a clinician, that is my first priority. This is why we brought up this policy forward. And I imagine not everyone realizes that most dialysis patients are on Medicare, and it's not only patients that you might expect. So this is really important, who is impacted here. So end-stage renal disease is one of the only conditions in any healthcare that qualifies someone for Medicare regardless of age. And a policy this has been in the book since 1973. The reason I'm sharing this is, as was stated in the beginning, most of these policies and reviews were really initiated by the people impacted under traditional Medicare, not Medicare Advantage, but traditional Medicare, typically 65 and older. But in this specific population, we are now touching working age adults with kidney failure who are on Medicare precisely, perhaps, because they have this disease, right? And they, again, access to dental services varies dramatically. That's a whole other issue. But typically, because Medicare doesn't cover prevention, they would not have access to dental services. Just to give you a sense of what these numbers are, the people with end-stage renal disease under 65, again, this is perhaps really surprising, is close to 240,000. And those that are 65 and older, it's about 325,000, right? So it's a really substantial younger population here where that this is going to have a significant impact. Again, the story of these patients is well known. Their life is basically structured around all of the things that happen around hemodialysis, medication schedules, access, and here, again, not understanding the impact on poor oral health, on inflammation and other, systemic effects was really telling. I do want to highlight, Mike, thank you for pointing this out, the lack of clinical evidence. As you saw in the previous report, we had at least 5 clinical guidelines recommending that oral health is either looked at, assessed, part of the treatment and coordination care, and here we didn't have that. But the evidence around inflammation was so strong that we were able to finalize this policy and change that payment policy. And what is even more phenomenal is because we received additional feedback from stakeholders, we were able to do that, prior to, during, and after dialysis, which again, to address this issue, you shouldn't wait till the very end to do this, but if you have end-stage renal disease, you can. So just very briefly to understand that this is a completely different population that's impacted and really providing very meaningful access to dental services for those who don't have it.
Great, thank you for that, Dan.
Yeah, thank you. It's quite interesting, the two studies being different. With end-stage renal disease, it's a very subtle effect. You don't have a triggering effect like you do with osteonecrosis of the jaw and like the medication induced and an extraction. Okay, so with dialysis, you've got chronic periodontal disease, which is a disease that has to be treated over many years. And so I think it's great that there's coverage for the dental exam. What's not clear to me is if there's ongoing coverage for treatment, like dental treatment, scaling, rip planing, periodontal maintenance,
There is
visits after.
There is. It's covered exam and treatment.
That's great, because in this situation, it really does require ongoing care. I think ultimately the difference to me, and what I don't hear is nephrologists telling me, hey, we need to get all these patients in for clearance is unlike the oncologist. They'll tell me we really need to get these patients in because they see the impact on the oral health in the clinic in a much different way. When someone gets ONJ, it's a real big event and treatment has to stop. And with kidney disease and periodontal disease, I think it's such a long-term treatment. Periodontal disease is notoriously hard to measure. So it's just a little bit more complicated to understand the true effect. So I'll leave it at that.
Great, thank you all. This has been wonderful initial reactions, and it's going to lead to our moderated discussion. I'm turning it over to Elizabeth now.
Thanks, Lucy, and thanks everyone for wonderfully thoughtful comments. I put something in the chat. I will motivate maybe some additional contributions here. We are going to start some moderated discussion with our authors. But while that's ongoing, I really would like to welcome folks who have been participating in sort of listening to these talks to throw your questions in the chat. We'd love to amplify that and get the answers to any questions you have. And we'll take some time to have some moderated discussion here with our authors, and then we will pivot in a little bit and have some discussion with the discussants. So I think the first thing I want to do is talk to David a little bit. So, you know, a lot of what we end up having to do, and this is very much the case of what was going on here with the reports that we're discussing here today, is, you know, figuring out how we synthesize what is out there in the evidence base and help those who need to make decisions, whether we're talking about health systems or payers, right, to figure out what they can actually do and what is indeed about the evidence. And so one question that I would have is, if you've got health systems or payers in this audience here, and they're trying to think through, and I do apologize, I feel like I am picking up a fair amount of background noise, so I'm just going to ask other folks to mute if they are not speaking. Thanks. So if we've got like a health system or a payer in this audience, and they're trying to think through whether to require a dental evaluation before initiating chemotherapy, what would you tell them in sort of plainly, right? Like, is well supported by the evidence, and where would they be getting in front of it?
Thank you. I think I was muted there. I think a couple things come to mind. One of the things that I found when looking at this body of studies was that they didn't quantify very well the overall state of dental health prior, you know, at the time of entry into the study, that they sort of included all comers. It's probably included patients with fairly severe problems and also patients who had very few problems. And that, you know, that heterogeneity of the patient population was not able to be sort of factored into trying to understand the analyses, which I think makes it hard for trying to recommend to the physicians who are the most high-risk patients based upon their prior dental health. I think the other thing that comes out, though, is really the intensity of the cancer treatment. Mm-hmm. Patients who get very intense multi-agent, multi-round chemotherapy, and patients who get these sort of combinations of both radiation therapy and chemotherapy as sort of neoadjuvant approaches and sort of post-radiation therapy treatment regimens seem to be at higher risk. And so that sort of, you know, sort of plays into it. I think you can have sort of a universal recommendation that everybody should get evaluated, but I do think it's to sort of think about who are my highest risk patients and, you know, where do I really want to make sure that they get some some evaluation and treatment done, before these intensive treatments start.
Mhm. Great, thank you. And I kind of want to go a little bit adjacent to that, which is thinking about how a number of professional societies already recommend pre-chemo dental evaluation. Where did the evidence align with that, and where does it diverge from that? And what should audiences sort of take away from that kind of disconnect?
Well, generally when and again, we looked at the guidelines about 3 years ago. So this, I think things might have evolved since then, but that these were kind of conventional expert-based recommendations. So they were recommendations based upon sort of these disease models, which didn't have generally much specific evidence that was sort of brought into the recommendations. I think it's a slowly evolving field. I mean, there are new studies that come out, a few good studies every year, and that this could move in the direction of making these recommendations more evidence-based. And so I think it's just something to sort of communicate with these guideline organizations. I also think that, even though we searched NCCN and the American Cancer Society, we didn't find much in the cancer organizations about dental care. And so it might be important to sort of bring them into the discussion.
Great, thank you. I'm gonna turn over to our other author for just a moment here, and want to kind of look at that connection between periodontal disease and CKD progression. So, how confident should clinicians and policymakers be in the link between periodontal disease and CKD progression, given the sort of small and mixed methods evidence base that you were working with? And what were some of the biggest challenges you faced in synthesizing this literature?
Yeah, thank you for that question. And actually, also I want to thank Michael for pointing out that inflammation is not the readout, right? So for CKD, however, inflammation is considered I would say one of the triggers. So oral health. While we were researching this particular topic, I happened to read, some of the dental literature, and one of the many dentists, I think it's a known saying among dentists that oral health is overall health. So if you think of it like that, the fact that there is inflammation affects your oral microbiota, and eventually that inflammation appears, in fact, not just in CKD, but in other diseases as well, to actually increase the level of inflammation everywhere else. So from that point of view, even though it's an indirect readout, my argument would be, I'm not a clinician, but my argument would be that reducing inflammation has to have a downstream effect on the disease. And from that point of view, I would say that I'm quite comfortable saying it could be, an indirect readout, the inflammation. Having said that, we should not stay away from actually measuring kidney function outcomes in these types of studies, and it's unfortunate that they were not done for these studies. However, thinking again about the challenges in bringing all of these data together, we had to spend quite an amount of time looking at the various, even though there were only a few studies that reported on kidney function outcomes, when we collected those data, we had to make decisions reluctantly to not include some of them, because they only showed up in one study and they were not going to contribute to the evidence. And in this context, I also want to mention there was only the one study on endocarditis, which Michael mentioned, and it is a significant finding. However, I didn't bring it up here because it was just in one study. Having said that, the main challenges there were actually it was a diversity of outcomes from paper to paper, but not something that was consistent, and so collating all of that and trying to slice and dice. The other challenge is I could not find any good source to say what is a clinically significant reduction in CRP. CRP could reduce just a little bit. Is that clinically significant for CKD? I couldn't find any studies that actually have investigated the level of clinical significance. We know statistical significance, but whether it is clinically significant or not, I think that still remains, in my mind, a question. If anybody can shed light on that, I'd love to hear it. So these are all the factors that went into why we fashioned the report the way we did, focusing on what we saw consistently across studies.
Can I just add something about the CRP? The American Heart Association just came out 2 months ago, included CRP different levels as risk levels for cardiovascular disease. They've never done that before. It was yes or no. Now they actually have it. It would be interesting to use the same type of thresholds maybe for chronic kidney disease as well. It's very possible. So that's an interesting paper that just came out a couple of months ago.
Yeah. Thank you. I did see that too. Yeah.
So I have a question actually for both authors, and so we can go, whichever one of you wants to just volunteer to go first. But I feel like we're constantly on this, I don't know, we ride this struggle bus, where policy decisions are based on a preponderance of evidence, right? It's not going to be like one study that is going to serve as the basis, oftentimes, for a lot of decisions. And yet when we go and actually dig into the evidence base, it is oftentimes very difficult, and it bears out in what you all were presenting, right? To actually find what the preponderance of evidence actually shows, and shows consistently, and thus that we can base decisions on. So as you kind of think about that as folks that do systematic reviews, and in the context of the clinical areas that we are talking about here, what would you say are some of the most critical gaps in the evidence base that really need to be addressed to help inform key clinical or policy decisions, again, in the purview of the topics that we're talking about here? And if you had to prioritize sort of one or two next steps for research, what would those be?
Yeah, so
Nirmala, do you want to go first?
Yeah, I can take this to a certain extent. So the one thing I'll say, and this has nothing to do with the science at some level, but that all of the cohort studies, all of them were done outside the US. And similarly, many of the primary studies were done outside the US. So I have a feeling, I want to say that there's not that much acknowledgement of the link between dental health and overall health in the US enough to do these types of studies, because we have the data, we have the databases, and we have the population. So why not do the studies, right? So I was very surprised. Actually, going in, I thought most of the studies will be in the US. And when we actually got the results, we found maybe one or two, but most of them are outside the US. And some of them were in countries you wouldn't imagine would be using this kind of approach to treat disease, So that would be one of my main, if I can say I want to sponsor an idea, that would be one of the ideas I would sponsor.
So thinking actually pretty upstream about sort of getting an understanding of the relationship between these different aspects of health, and having that as a motivator for driving more research in this area.
Absolutely.
David, how about in the context of your sort of clinical topic area? How might you think about something like that?
So, I think the methodology of systematic reviews is well developed, and there are good tools for rating the quality of individual studies. That said, it's very frustrating to have a full-blown, big-time systematic review that then reports that there's insufficient evidence to draw good conclusions. And so we get into this sort of problematic area of, we know that there's limitations of the studies. What can we say, knowing that it's imperfect evidence? And I think that I don't know that there's a real sort of perfect solution to that problem, but that the degree to which you can describe the limitations of the studies to help people sort out, well, what is and is not there. Because yes, policymakers need to make decisions, and they need to make decisions based upon what is currently available. And so, I think that that's when you have sort of reports like this, you've got to sort of figure out, okay, where are we going to end up, because we know that there's limitations in the evidence base. In terms of future research and what should be encouraged, my impression is that probably the reason you're not seeing a lot of good, large-scale, randomized controlled trials of these questions being conducted in the United States is that there isn't really financial support to do that. It comes down to, even though the NIH has a large budget, it's a budget that's being spread over a really broad range of different clinical areas. A lot of the famous large-scale randomized trials of the last 10 years or so have basically been funded by drug and device makers who have sort of a vested interest in being able to pay for these treatments. I don't know if there are entities that are willing to pay for routine dental care for the purpose of conducting randomized controlled trials. I'm sort of describing a barrier without describing a solution to that barrier, but I think it's something that it would be good policymakers to think about, and to how to sort of partner with research organizations to get, because it would be really feasible to do some fairly straightforward, randomized controlled trials that could be completed within 3 or 4 or 5 years that could give us better evidence about these issues that we're talking about today.
Can I give a little cynical context here as well? David, you're 100% right. Here's the problem. I'm talking from academia right now. Promotion and tenure, you need to do research. Doing a systematic review today is considered research. In 2018, there were more clinical trials and systematic reviews in PubMed. Last year and this year, there are 3 times as many systematic reviews as clinical trials. Mm-hmm. So the 2 problems. 1, we don't do clinical trials because it's easier, quote unquote, to do systematic reviews. And 2, the systematic reviews you're going to find are going to be based on the same clinical trials, because enough aren't enough. So we have a problem from a methodological standpoint when we even review the evidence, that these systematic reviews might not be at the level that we want them to be either, because of the lack of clinical trials that are behind them.
Elizabeth, I love your solution. It is really political will and money. I love it.
It's as I'm listening to this, I was like, David, you did bring solutions. What are you saying? I definitely heard a solution. I heard the solution is political will and money. So yeah. Good deal.
But if I may address one thing that David mentioned that is so important, I think just understanding the burden of disease of the population at the start of this is a big challenge. We really don't have good ways of doing that. And I think with the advancement of AI and technology, we can do that, right? We can do today things we couldn't do 2 years ago. Heck, we couldn't do them a year ago. And so I think here the challenges that you all described between the dental and the medical systems, in the heart of them is technology and the lack of health and information interoperability. That's solvable with technology and money, right? We now have access to some of the best real world evidence in a system where the dental and medical are connected. Again, you can do something that we couldn't do before. The role of AI in all of this space is, for me, actually very encouraging. And I think we will see some of this evidence move forward a lot rapidly than before. I would just say though, for these cases where the payment policies have already been changed, I don't know if this will be the best way to, funnel more money, because I don't know if someone would put the link to the AHRQ website where all of them were collected, but there were plenty of systematics review where it wasn't enough evidence to do anything. And so we actually have real gaps. We've identified real gaps where this type of effort could really move forward with some political will and money. And so again, here the payment policy, and I would just say that's a payment policy. It still doesn't mean that patients with end-stage renal disease can access care, because you need dentists to enroll in Medicare. You need for the patient to understand that they can get this care. You need for the healthcare system. I love who brought this up, that the nephrologists, the oncologists need to coordinate with dental around clearance and treatment. This is still work that needs to happen, even when you have the limited evidence resulting in a payment policy, but ultimately we want the patients to get the care they need.
Thank you. I see we've got a hand raised, we've got comments in the chat, so I just want to make sure that we are giving space to uplift those. I know Judith Ann Jones has made a comment around a key data source would be systems that use electronic records that integrate oral and systemic data. So a wonderful contribution that sort of dovetails with Natalia, some comments you were making as well. I see Anjali, you've got your hand raised, and I think that also Dan also wants to comment. So maybe I'll go to Anjali first.
Thanks, Elizabeth. It's Anjali, by the way. So.
Oh, I'm sorry. Thank you very much for correcting me.
So I had a couple brief comments. One is that we at AHRQ, I'm a medical officer at AHRQ, we've really been paying attention to this issue of like so many systematic reviews and not enough primary studies. And I think it's just, it's grown exponentially. And, one thing that we're thinking is one part of the solution to that is really making increased standards for justifying a systematic review, either through NASM or some of the other methodologic bodies and standards. Like maybe there needs to be more rigor in terms of when systematic reviews themselves are funded. Another thing that I was just considering about the comment of how so many of these studies came from outside the US. And I think part of the issue for something like dental care, and often for like mental health care too, is that it's very specialty driven. Like everything is specialty driven. And so in the US, and so I do think that having a more holistic, or even like a group that's more dedicated to really seeing the whole person, and of course these systems talk to each other. I mean, our teeth are in our body, and our brains are, partially in our intestines and all of that. So I wonder if that's part of why other countries are able to like view things a little bit more connected at the outset. And the last thing is really a question, because I feel like 10 years ago or so, there was a lot of talk about pragmatic trials and really using real world data. And I just don't hear much about that anymore. So I don't know if anyone can comment.
I'm sure folks can comment. I sort of feel like Lucy might want to weigh in from a learning health systems perspective on that. So I don't know if anybody wants to jump in. And
let's go to Dan first, Elizabeth. Let's go to Dan first.
Okay, great.
Oh, I was just going to say, you know, a couple just comments to piggyback off what others have said. You know, one of the things at Kaiser Permanente that we discovered, and one of the reasons why I think we are doing a lot of the integration is because we had doctors who said, like, we have a problem. We have cancer patients who we tell them to get a dental exam. They don't have Kaiser Dental, they have some other insurance, and they go out and they can't get dental care and they can't afford it. And then once they do get the dental exam, they can't afford any of the care. So could you guys do it for us? And so because we're all one budget, it makes a lot of sense. And because we kind of know each other, it makes a lot of sense. And I think that that kind of connectivity is something that is taken for granted in a lot of systems. There are other systems out there, academic health systems, VA, FQHCs that are integrated like that. But do they have the kind of connections financially and socially that the organization really needs to kind of put up a more robust ability to manage these patients between medical and dental? And then the other thing I was going to say, which is I think an important point and why this research is so important. I'll give you another example of a dental exam that has been recommended. It's recommended in my institution, and that's that patients who undergo total joint replacement get a dental exam prior to their joint replacement. And I think there's very little evidence around that. That's more of sort of like some orthopedic surgeons think it's kind of just optimal. It's kind of based on the literature around infected joints and dental caused from dental disease. But it really creates a whole backlog of problems for patients who then have to go out and seek dental care and get dental treatment. So it's for maybe things that aren't that important in their overall journey of care with their joint. So it's really, really important that we do have high quality evidence and not just kind of go, well, you should get it and make the patient jump through a bunch of hoops to get things done that aren't necessarily going to benefit them. So I'll close with that.
Thank you.
And if I could just comment from a learning health system perspective, I think, you know, it's already been mentioned in the original report discussion that in the United States, dental health care has been carved out as a separate sort of level of care and not covered under traditional insurance and not thought of in the same kind of way. And so I think the places like Kaiser Permanente Northwest, and there are others across the country, that are moving into medical dental integration where the records can talk to each other. It's going to open our ability to do some of these pragmatic trials that were discussed.
Thanks, Lucy. I think I am going to pivot now to talking with our discussants. And I think as a bridge question, what I would like to do to sort of kick things off, and folks should feel comfortable to just sort of chime in here. But thinking about rapid evidence reviews, as we've been talking about here, they're really designed to be able to inform policy and policy decisions on pretty compressed timeframes. I think Michael referenced, you know, things needing to take 1,000 hours or so. And that is definitely not what we're talking about with the work here. So that can involve real trade-offs when it comes to methodological rigor and other types of considerations that might need to be made. So when you're talking about an evidence base that is observational, that is heterogeneous, and is still evolving, all of those things, I think, characterize some of what we've been looking at here today. What kinds of standards and guardrails should guide how that evidence is getting used, particularly when we're talking about coverage decisions and things like that? And who do we need to make sure is in the room and at the table when those different judgment calls are being made?
Let me address the timelines, because some of them, it's important to understand where they come from, and they're statutory mandated. They're in the law, right? CMS cannot say, okay, take a year to develop this. You know, the proposed rule needs to come at a certain point. The final rule needs to. So understanding that these timelines are there, what was really instrumental, and I love that we heard from David, sort of the initial, we had such a compressed timeline, but you know what? Over the next year, 2, 3, we actually had a process that was, you know, informed by the feedback we were getting from stakeholders, and then we were able to schedule these, right, and not be subject to such compressed timelines. So if you have a process, if you establish a process, then you're not driven by, okay, you have 2 months to do this. So I think having that at the leadership level and sort of understanding where the policies are going next is very important to drive this in a way that produces the highest quality evidence that can be then incorporated into whatever the final rule is. Yeah.
So one of the
We were
problems,
very ambitious, and I think the other piece I would just say, we were very ambitious and worked with incredible teams, and they were able to produce multiple of these in a very compressed time. I think with AI, these timeframes are going to shorten even more. So we can do more now than we did before.
so one of the problems I see here is that if you take chemotherapy for different type of cancers as an example, the research, the level of research is exponentially bounce. I mean, it goes so fast. So having a review that is a couple of years old, it's old already. And there's no criticism of what's done here, but this is unfortunately what we have. So having these rapid reviews, I think, is absolutely essential because of this rapid progression of, I mentioned CAR cells and CAR T cells and so on and so forth, right? If you look at bone marrow transplantation, other type of transplants and so on and so forth that are cancer related, you cannot compare data 10 years ago to what's happening today. One solution, and I don't know if it's a viable solution, Natalia, you know more about this than I do, is doing living reviews, meaning you have the initial review and then you have databases. I mean, that's what we use. We have AI looking at primary studies, 15 databases every 4 hours. And then we figure out if some of these new primary studies that are found, is that going to impact the systematic review that we have? And if it does, will that then impact the recommendation? That takes more AI than we know about to do today. It also takes more work to do it. But I think moving forward, considering the technology, how fast that is moving, and Natalia, you mentioned it, specifically with AI, these living reviews needs to be a must moving forward as far as I'm concerned.
I want to give Dan some space to weigh in as well if he wants to jump in here.
Well, I mean, I don't live in the world of how coverage is decided. You know, it's such a diverse healthcare system in the United States, from commercial plans, and it's really. In fact, I was at a meeting, Michael, with you, and who was that European physician talking about?
Per van der Beek.
Yeah, and he was like, I don't. He was, where was he from? Norway or something like
Norway.
that. And he's like, the health system here is so complicated. It's very difficult to navigate it. And that's even doubly true when you consider that there's dental coverage and medical coverage. I mean, frankly, if we just had medical and dental coverage, we wouldn't have to talk about, is it useful for a patient to get a dental exam prior to kidney hemodialysis. Nirmala, you joked about like you started flossing your teeth more after you read these, but really, like if you can increase the health of the population, you're going to reduce a lot of these sort of niches, kind of undervaluing it, but niche kind of situations where we do need special coverage for them. So it's just kind of it's hard in the United States with these different systems that people navigate the health system.
Yeah. Excellent points, I think, for on multiple fronts from each of our panelists here. I know that was sort of a way for us to be thinking about how we move from the way that we are using these kinds of reviews and what we need to think about there. I think to kind of bring us more into some of the practice space of these questions would be to think about, you know, in your experience, are there models or solid examples of health systems that are successfully integrating dental services into medical care pathways, particularly for complex patients, without creating, this sort of builds on this issue of the complexity of our system, right? Without creating delays or additional burden. Like, are there kind of bright spots that folks can point to for that?
I'll go first, perhaps obviously because I'm with an organization that integrates medical and dental services. Not all of our patients that have Kaiser Medical have Kaiser Dental. So we don't provide dental services for those patients. And there are dentists in the community that will see patients that have the training and expertise and kind of the calibration, I should say, around what does a patient need who is going to be undergoing chemotherapy and the use of bisphosphonate medications. What do they really need to get them healthy to get through this treatment? And there's a whole bunch of complicated issues that we can get into later, but education and training and just what is really needed for these patients, given the fact that their complex medical history kind of limits what kind of dentistry you may want to offer them. But I do think the other bright spots are, there's integrated health systems, health partners in Minnesota, the VA system, FQHC. I think academic health systems, in fact, these models around dental examinations prior to transplants and things were largely developed in academic health settings where there were training programs for oral surgery and general practice residents. And I think that's where this sort of integration probably came from at the hospital level. So I think that the more that hospital systems and health systems incorporate dentists into their programs, either through special cases like this or through coverage, is going to benefit patients in these more complicated health systems that are dealing with more complicated medical conditions.
Elizabeth, I love this question. And again, similar to that, as someone who's practiced in a fully integrated care at NIH, where we provided care for all the patients that are on protocols, again, very narrow patient population, very complex, right? They're there because they're getting, experimental treatments, first of its kind, right? But there was a dental clinic, and guess what? We were one of the teams that provided that integrated care. We had access to the full medical record. They had access to the full dental record. This is just simply not the reality of practicing dentists on the outside, right? But when it works, it's really amazing. The other places that I've seen incredible light in this space is places like the M.D. Anderson Cancer Center. They actually always had oral health care as part of the care pathway for the patients. But the difference now is that they actually can get paid for it, right? Before they're like, we cannot let someone with 5 abscesses start chemotherapy because they're going to have, sepsis. And so we don't want to be dealing with that. But now their workflows are still there. There is now just the payment rather than doing all of this pro bono and calling the surgeons last minute, the patient is ready for transplant and they're like, oh, there's an abscess. Like we now have a place where we can actually sequence the care and get providers paid for it. So there are some examples, and I'm so happy you brought this question, because this is back to the question, how do you translate this to everyone who has cancer or everyone who needs a transplant? How does this become part of the organizational DNA? And there's a lot of change management that needs to happen for everyone. And how do we make sure dentists recognize they can deliver the care and get paid for it? They need to enroll, right? They need to coordinate care with the physicians. That is something, behavior change and change management on the private dentist side that is going to take a while.
So maybe someone can answer my query here, and that's a question of a question. What happens in the VA system? I know not every veteran has a right to have dental care. It's only if something happened during the care and so on and so forth, during the service and so on and so forth. But there you have combined systems. You have medicine and you have dentistry. And I see very few studies coming out of the VA system. You also have medically complex patients there as well. So I'm surprised, and maybe someone can help me. Why haven't we seen more primary studies coming out of the VA system that has the setups here to do all the stuff?
Dental coverage in the VA is based on disability status, and it's only available for those who are 100% disabled, and that is a very, very, very small proportion of the veterans. Therefore, the majority of veterans getting care in the community, and that dental care is not integrated with their medical care. That's a short answer to a bigger problem.
Wow.
Yeah.
Thank you.
Well, I think there's sort of layers to what we mean when we talk about integrated care.
Integrated, coordinated, not the
Right,
same.
yeah.
Exactly, Elizabeth. Yeah.
Yeah. Love that, turning the tables and being like, I want to answer your question with a question. That's great. I kind of want to build a little bit, Natalia, on where you were going, which is to be thinking about, you know, if we want to be moving more in that direction, what are the different things that we need to be thinking about from a system, a policy, a workforce level, right? That can help sort of position folks to be able to deliver care in this way, in a better way. And obviously I'm building on what Natalia was talking about, but this is a question for everyone.
Yes, thank you. What a great question. All of us have had the opportunity to speak with someone who speaks a foreign language. And imagine if you don't know that language and you try to build a system that works for the patient. I mean, I know this is a bit extreme, but this is what we're trying to do. Medicine and dentistry don't speak the same language. And what I mean by that is dentistry doesn't use diagnostic codes. So even at the very basic level of like understanding what the condition is, we don't exchange that communication. I am not suggesting that implementing diagnostic coding is going to solve this problem, but it's going to at least start that path to a shared language where we are really on the same page, hold accountable to the same metrics that are outcome driven. Medicine has had many of these. We don't. Ours are mainly process. And so I think that common language is really, really important, starting with diagnostic codes. And then I mentioned the technology disintegration that currently we're in. That would require a lot of will, I would say, on the dental, but also on the medical side, because I am also hearing from medical providers who are like, don't ask me to do one more thing. I'm done. You know, there's 30 minutes in the appointment. I am not doing an oral evaluation. And so how do you make sure that both sides have the technology and the language needed to do and help each other provide the best outcomes for patients? We know that in America, out of the 330 million Americans, about a third of them, 33% to be exact, will only see a medical provider. They will not see a dentist, okay? That 1/3, okay, has no interaction with the dental delivery system. How are we talking about oral health, inflammation from the oral cavity? What is that language? And then there's a smaller proportion, about 9%, that will only see the dentist, okay? How are we talking about high blood pressure, diabetes, and all the other things, right? This is what I mean by shared language, that we are able in our workflows, number one, in our systems, integrate pieces that are relevant to what the other side needs. Because I would be the first one to say that my medical colleagues don't need to know anything about the number of cavities or the level of pockets around 3, but they do need to know that there is an infection and there is a risk of systemic complication. And I need to be able to translate my comprehensive exam into something that's meaningful for medical providers. That, again, I think this is a language, broadly speaking, issue of where we can communicate. The same way dental providers may not need the full, 180-page summary of the medical record, but they do need to know all the medications. They do need to know the latest labs. They do need to know the comorbidities impacting the patient, right? So let's find these core elements that we need to exchange and make that happen in real time, because it can. Again, if there is a will and money, this is solvable today more than ever before. I don't know how many of you were able to join the hackathon. Exciting stuff is happening. They were able actually to get the information from a medical record for a cancer patient and integrate the output into a dental record. Like, it's possible, right? If you put technology and people in the room, they can make it happen. It's just not happening at the systems level. Yeah. So this is the shared language, technology are things that are just going to help this become easier. Not removing some of the barriers, right? Because there's so many, but removing some of these big barriers.
Great, thank you. Michael and Dan, do you want to chime in?
I mean, I would just say, I mean, I agree with Natalia. The thing that I often find what brings medical providers and dental providers together is when they can help each other solve a problem. You know, if I have a pediatrician who has a patient and they do an oral exam and the patient has a bunch of cavities, it's great if they know who to contact to get that patient seen by a dentist. And you know, if I have a question about how to manage a patient, if I'm going to do a minor oral surgery procedure, it's great if I know which doctor to contact and with a very specific question. And then the big thing is then having the organizational support to make that happen in a practical way that's timely. So but I think there will be a natural convergence of collaboration when you know, when there's mutual benefit and motivation to do that, and ease.
Yeah, so let me add trust to that as well. And we also need to educate our medical physicians, medical college, for the means with oral health and so on and so forth. One classic example that usually hits them over the head is when I tell them that someone with severe periodontal disease is the equivalent of having your entire palm of your hand infected. Would you treat that or wouldn't you treat that? It's the same type of that's the surface area we have in the periodontium, right? Now, Natalia, I agree with you 100%, but I see a big barrier here. And that is, if I have access to all the medical records, I better know what to do with them. And I'm not sure that the education we have today in dental schools in the United States is at the level where graduate dentists would understand all that information. So I think we need to go a little bit backwards in order to go forward. But I agree with you. Hey, go for it. We should have records. But I can also see all the lawyers sitting out there saying, what, you missed that? It wasn't a medical record. You should have paid attention to that. Well, I didn't know what that meant.
Just to clarify, I was suggesting that dentists have access to key elements that are critically important for their care and not to the 180-page full medical record. Because to your point, that could be overwhelming and they're technically not trained to interpret all of that. And so I think here recognizing, again, what are the shared common elements that we need to exchange to, again, provide the best outcome for our patients. And in all transparency, medical providers get only 2 hours of oral health instruction. So it's not that like dentists are not trained, but you know, the medical side also doesn't get enough oral health education. But if we truly are here to improve the outcomes for our patients, again, finding these pieces, these, you know, building these channels of information and communication of relevant things that we can interpret and integrate in our care is very important. And I want to add something that was not mentioned, but it's really important. Part of the Medicare rule, in order for these dental payments to actually become actionable, required an exchange of information between a medical and dental provider. It's in the payment rule. Before you get any money, that exchange needed to happen. So I think policy also can help in that space, is saying, look, you can do the service, but in order to get paid, you need to exchange information. And so how is that done? No, you know, who operationalize this? Still questions that need to be answered. Yeah.
All right, I am going to jump in. I think this has been a phenomenal discussion, and love how lively it was. I really do. And I'm also delighted that we were able to dedicate an entire grand round session to dental care and the integration of dental and medical care. I think this is a deeply important issue. And I'm delighted that we were able to spend some time talking through it. So I do want to thank everyone, and I hope that all of the that have joined us today will join me in thanking our authors and our discussants for an outstanding conversation today. And also want to thank our partners, AHRQ and the SRC as well. You can see in the chat the CME survey link has been dropped in there for anybody interested in seeking continuing medical education credits. So that's there. And we will post the meeting's recording as soon as we can and announce the next EPC Grand Rounds theme shortly thereafter. So thank you again to everyone. This was fantastic, and I hope that everyone has a wonderful rest of their day. Thanks.